Good morning. I'll be discussing on submacular hemorrhage, role of TPA, gas and anti-VEGF. I have no financial interest. So submacular hemorrhage is hemorrhage in the potential space between the neurosensory retina and the RPE. It can be caused by the neovascular AMD and PCV most commonly, then retinal artery macroaneurysm, trauma, myopia, injured streak. It may lead to the photoreceptor damage within 24 hours by sharing of outer segment of photoreceptor, impaired transport of nutrients, direct toxicity by iron, fibrin and simosiderin. So timely intervention is extremely important. Treatment options available are anti-VEGF monotherapy, pneumatic displacement with anti-VEGF therapy, intravitreal TPA with anti-VEGF and pneumatic displacement, or pars plana vitrectomy with subretinal TPA with subretinal or intravitreal pneumatic displacement. Natural history has a very poor visual outcome. There is no gold standard treatment. Monotherapy with anti-VEGF showed some success. Anti-VEGF treats the underlying pathology. Expansile gas causes mechanical displacement of blood from the fovea, so there is faster visual recovery and it may even cause flattening of hemorrhagic PEDs. It allows to show, view the underlying pathology and perform the related investigations and treatment as per requirement. Anti-VEGF with gas has shown better result, but there is no head-to-head prospective trial. A CAD trial subgroup of patients with submacular hemorrhage had favorable outcome. TPA was first described by Wilson Harriot with intravitreal 0.1 ml, which catalyzes the breakdown of plasminogen to plasmin to cause clot lysis, liquefies the subretinal clot and hasten resorption of pre-existing hemorrhage. Intravitreal TPA with or without gas or anti-VEGF result is very good in small hemorrhage with shorter duration. Subretinal TPA following vitrectomy used in large, long-standing and more severe form of hemorrhage. It causes chemical lysis of clot with minimal mechanical trauma. Side effects may be photoreceptor cell loss, RP, pigmentary changes, exudative retinal detachment or hemorrhage, which are dose dependent. The vitrectomy allows a larger gas bubble. 3-line improvement in visual improvement is noted in 66% of population with submacular hemorrhage. No clear difference, but there is no clear difference between the vitrectomy with subretinal TPA versus intravitreal TPA without vitrectomy. But it has got advantage of subretinal pneumatic displacement, which exerts higher pressure, more effective after TPA-assisted clot lysis. Then prolonged face down positioning is not required and less chance of IOP rise, but there is high risk of macular hole formation. Vitrectomy with subretinal TPA with PFCL has been used to displace subfoveal blood. So we have few cases. First case is a 55-year-old female who came with 15 days history of decreased vision with 636 vision, known hypertensive, came with the left eye huge submacular hemorrhage, OCT showing multiple PEDs with subfoveal hemorrhage. So she was treated at first with intravitreal gas with anti-VEGF. 2 weeks later, vision improved to 6/18, but not much of displacement of submacular hemorrhage. So injection TPA was given intravitreally. 1 month post-injection, vision improved, but still there is persistent submacular hemorrhage. FFA showed a hyperfluorescence, but there is no definite diagnosis. Second dose of anti-VEGF was given. Post-injection, 7 days injection C3F8 was added. Later on, after 1 month, ICG was done, which did not show any polyp or BVN. So provisional diagnosis of retinal artery macroaneurysm or AMD was made and received 3rd dose of injection ranibizumab. Subsequently received 2 more doses of ranibizumab and vision improved to 6/9 with complete disappearance of submacular hemorrhage. Second case of a 75-year-old lady, known hypertensive with 1 month history of submacular hemorrhage with finger counting vision, FFA done elsewhere showing retinal artery macroaneurysm. So she was treated first with intravitreal gas with intravitreal TPA and anti-VEGF, but still not much of improvement. So C3F8 was re-injected, but still there is no improvement. So vitrectomy was done with subretinal TPA with C3F8 and aflibercept. So this video is showing a 23 gauge vitrectomy. After removal of the vitreous, the trichord-assisted complete removal of vitreous was done. Then special cannula was used, what Dr. Saravanan had shown. The 30 gauge cannula was introduced in the 24 gauge cannula and subretinal TPA was injected. Hemostasis was secured and fluid air exchange was done. So subsequently 2 more aflibercept was given, vision improved to 6/18 and there is complete disappearance of submacular hemorrhage. Case 3 had a 73-year-old male patient, known diabetic, with 10 days history of huge submacular hemorrhage with finger counting vision, FFA showing stipple hyperfluorescence, ICG showing multiple cluster polyps with a huge PED and subfoveal hemorrhage. So initially he was treated with intravitreal anti-VEGF with gas with strict prone positioning. Unfortunately, patient developed breakthrough vitreous hemorrhage with RPE RIP. Then the vitrectomy was planned with intravitreal gas and second dose of anti-VEGF. 1 month post-injection, vision was 2/60, but the hemorrhage has resolved. TPA was not used. So to summarize, we can see the patient with a AMD had a poor visual outcome. TPA was not used in all cases, but still the anatomical success could be achieved. So visual prognosis was better in patient with shorter duration and lesser retinal damage. Anatomical success could be achieved. Subretinal TPA was very effective in long-standing cases, especially when intravitreal failed. All the procedure has relatively less complication other than having a breakthrough vitreous hemorrhage or RPE RIP. So to conclude, timely intervention is extremely important. Intravitreal gas is effective in displacement of blood but may require multiple injections. Anti-VEGF has big role in treating the underlying pathology. TPA is effective in dissolution of blood clot but may not be mandatory in all cases. Subretinal TPA is more effective and safe in refractory cases, and visual prognosis ultimately depends on underlying pathology, presence of sub-RPE blood, duration of hemorrhage, size of hemorrhage and available facility.
Thank you.